The term patient-centered care is being rapidly advanced by the medical community. In the medical field, these terms are an innovative approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships among healthcare patients, families, and providers. The very first connections between nurse and patient are to establish an understanding that the nurse is safe, confidential, reliable, and consistent, and that the relationship is conducted within appropriate and clear boundaries. Establishing a therapeutic alliance or relationship with the patient takes time. The nurse-patient relationship is a creative process where each person brings his or her own uniqueness to the nurse-patient relationship. Historically, this was known as therapeutic use of self. A social relationship can be defined as a relationship that is primarily initiated for the purpose of friendship, socialization, enjoyment, or accomplishment of a task. Accepting any gifts from patients demonstrates a social relationship, but you do need to acknowledge the gesture. Another one would be considered going to social gatherings with others. A therapeutic nurse-patient relationship has specific goals and functions. Goals in a therapeutic relationship include facilitating communication of distressing thoughts and feelings, assisting patients with problem solving to help facilitate activities of daily living, helping patients examine self-defeating behaviors and then test alternatives, and promoting self-care and independence. The therapeutic relationship between nurse and patient differ from both a social or intimate relationship in that the way that the nurse maximizes his or her communication skills, understands human behaviors, and personal strengths to enhance the patient's growth. Upon meeting the patient for the first time, the nurse should set clear boundaries with the patient that must not be crossed from nurse-patient relationship into a social or intimate relationship. Increasingly, we are working, living, and caring for people from diverse cultures and subcultures whose life experiences and values may be quite different from our own. Values are abstract standards and represent an ideal, either positive or negative. A person's value system greatly influences both daily and long-range choices. Values and beliefs provide a framework for the life goals people develop and for what they want their life to include. Modeling is perhaps one of the most potent means of value education because it presents a vivid example of values in action. We all need role models to guide us in negotiating many of life's choices. But we also must be aware not to impose our value systems onto the patients. The orientation phase can last for a few meetings or can extend over a longer period. It is the first time that the nurse and the patient meet. When strangers meet, they interact according to their own backgrounds, standards, values, and experiences. The fact that each person has a unique frame of reference underlies the need for self-awareness on the part of the nurse. For the nurse, part of helping the patient feel comfortable with him or her is using AIDIT, which will provide the patient a little background on the nurse. For example, the nurse may say, "Hello, Mr. Smith. My name is Hannah. I have been a nurse for 9 years. I have been with General Hospital for 7 of those years. I have a lot of experience taking care of patients, and if there is anything that I can do to accommodate you, please help me by telling me anything I need to know." The nurse must build a rapport with the patient so that he or she will have trust in the nurse and the relationship can be maintained. Specific tasks of the working phase of the nurse-patient relationship that remain relevant in current clinical practice includes maintenance of the relationship, gathering further data as necessary, promoting the patient's problem-solving skills, self-esteem, or use of language, facilitating behavioral change, overcoming resistance type behaviors, evaluating problems and goals and redefining them as necessary, and promoting practice and expression of alternative adaptive behaviors. The termination phase begins in the orientation phase. It also may be mentioned when appropriate during the working phase if the nature of the relationship is time limited. The date of the termination phase should be clear in the beginning. In some situations, the nurse-patient contract may be renegotiated when the termination date has been reached. In other situations, when the therapeutic nurse-patient relationship is an open-ended one, the termination date is not known. So, for an example, the student may say, "Mrs. Rodriguez, as I mentioned earlier, our last meeting will be on October 27th. We will have 3 more meetings after today." The termination phase is the final integral phase of the nurse-patient relationship. Termination is discussed during the interview and again during the working stage at appropriate times. Termination may occur when the patient is discharged or when the student's clinical rotation ends. Basically, the tasks of termination are summarizing the goals and objectives achieved in the relationship, discussing ways for the patient to incorporate any new coping strategies learned during the time spent with the nurse, reviewing situations that occurred during the time spent together, or exchanging memories that can help validate the experience for both the nurse and the patient and facilitate closure of that relationship. Termination has been successful when changes with the patient are discussed that have happened during the relationship and the outcomes are all evaluated. Consistency includes ensuring that a nurse is always assigned to the same patient and that the patient has a regular routine for activities. Interactions are facilitated when they are frequent and regular in duration, format, and location. Consistency also refers to the nurse being honest and consistent in what she is saying to the patient. Pacing includes letting the patient set the pace and letting the pace be adjusted to fit the patient's moods. A slow approach helps reduce pressure, and at times it is necessary to step back and realize that developing a strong relationship may take a long time. Listening includes letting the patient talk when needed. The nurse becomes a sounding board for the patient's concerns and issues. Listening is perhaps the most important skill for nurses to master. Truly listening to another person, attending to what is behind the words, is a learned skill. Initial impressions, especially positive initial attitudes and preconceptions, are significant considerations in how the relationship will progress. Preconceived negative impressions and feelings toward the patient usually bode poorly for the positive growth of the relationship. In contrast, the nurse's feelings that the patient is interesting or a challenge and a positive attitude about the relationship are usually favorable signs for the developing therapeutic alliance. Comfort and control is promoting patient comfort and balancing control, usually reflect a lot of caring behaviors. Control refers to keeping a balance in the relationship, not too strict and not too lenient. Patient factors that seem to enhance the relationship include trust on the part of the patient and the patient's active participation in the nurse-patient relationship. Inconsistency or unavailability are major factors that hamper the development of a positive relationship and can lead to mistrust. And that brings you into mutual avoidance. This is where the nurse and the patient are reluctant to spend time together and the meetings are very sporadic. These can have a very negative effect on the patient's therapeutic outcomes. The nurse's lack of awareness of negative feelings can contribute to a lack of progression of a positive relationship as well.
Empathy is a complex, multidimensional concept that has moral, cognitive, emotional, and behavioral components. Perhaps Carl Rogers explained empathy most clearly, stating, "It means entering the private perceptual world of the other and becoming thoroughly at home with it. It involves being sensitive, moment by moment, to the changing felt meanings which flow in this other person, to the fear, rage, tenderness, or confusion, or whatever it is that he or she is experiencing. It means temporarily living in the other's life, moving about it delicately without making judgments. And therefore, empathy signifies a central focus in feeling with and in the patient's world. According to Mercer and Reynolds, it involves accurately perceiving the patient's situation, perspective, and feelings, communicating one's understanding to the patient, and checking with the patient for accuracy. Acting on this understanding in a therapeutic way towards the patient. A simple way to distinguish between empathy and sympathy is that in empathy, we understand the feelings of others. In sympathy, we feel the feelings of others. When a helping person is feeling sympathy for another, objectivity is lost, and the ability to assist the patient in solving a personal problem ceases. Furthermore, sympathy is associated with feelings of pity and commiseration. Positive regard implies respect. It is the ability to view another person as being worthy of caring about and as someone who has strengths and achievement potential. Positive regard is usually communicated indirectly by the following actions rather than directly by words. Effective communication can take place almost anywhere. However, because the quality of the interaction, whether in a clinic, a clinical unit, an office, or the patient's home, depends on the degree to which the nurse and patient feel safe. Establishing a setting that enhances feelings of security can be important to the helping relationship. A healthcare setting, a conference room, or a quiet part of the unit that has relative privacy but is within view of others is ideal. When the interview takes place in the home, it offers the nurse a valuable opportunity to assess the person in the context of everyday life. In all settings, chairs need to be arranged so that the conversation can take place in normal tones of voice and eye contact can be comfortably maintained or avoided. For example, a non-threatening physical environment for nurse and patient would involve assuming the same height. So this would be either the nurse and the patient are both sitting or standing, avoiding a face-to-face stance when possible, a 90 to 120 degree angle or side-by-side position may be less intense and the patient and nurse can look away from each other without discomfort. Another would be providing safety and psychological comfort in terms of exiting the room. The patient should not be positioned between the nurse and the door, nor should the nurse be positioned in such a way that the patient feels trapped in the room. And lastly, avoid having a desk barrier between the nurse and the patient, as this will cause the patient to feel uneasy and as if the nurse is an authoritarian figure and the patient will be untrusting of them. In the orientation phase, student or nurse tell the patient who they are, what the purpose of the meeting is, and how long and at what time they will be meeting with the patient. The issue of confidentiality is addressed during the initial interview. Once introductions have been made, the nurse can turn the interview over to the patient by using one of a number of different open-ended statements, such as, "Where should we start?" or "Tell me a little bit about what's been going on with you," or "What are some of the stresses that you have been coping with recently?" "Tell me a little bit about what's been happening in the past couple of weeks." Perhaps you can begin by letting me know what some of your concerns have been recently, or "Tell me about your difficulties." Communication can be facilitated by appropriately offering leads like "go on," or making statements of acceptance like "yeah," or "uh-huh," or otherwise conveying interest. Eye contact should be done in a way that culture is taken into consideration. Be aware of the meaning of direct and indirect eye contact in your patient's culture. Body language can be interpreted in a way a person stands, sits, or facial expressions. It can indicate receptive behaviors or resistance. Proxemics is the personal space that is comfortable for individuals. In the US, intimate distance is 0 to 18 inches. We normally reserve this type of space for those we feel most safe with, usually our spouse, children, or parents. Personal distance is 18 to 40 inches, and we generally see this in personal communications with friends and colleagues. Social distance is seen as a 4 to 12 foot space. We keep this distance between strangers or new acquaintances in public places and formal gatherings. Public distance is anything greater than 12 feet. When complete strangers are any closer than this, we begin to feel uneasy. If the patient is uncomfortable with the amount of space between you and them, then they typically will tell the nurse or just move to what is comfortable. Do not force the patient to be closer than what is comfortable either. This can lead to violent or ill behavior. Vocal qualities, such as voice loudness, pitch, rate, fluency, these all will also set the tone between the nurse and the patient. It can be how a word is emphasized, and like how they say, it is not what you say, but how you say it. So realize that if the nurse's tone is high and fast, she may sound scared or angry, and the patient will pick up on this and react accordingly. Verbal tracking is just that. It's tracking what the patient is saying. Individuals cannot know if you are hearing or understanding what they are saying unless you provide them with cues or feedback. Verbal tracking is giving neutral feedback in the form of restating or summarizing what the patient has already said.